Okay, so I'll just talk about the scripture reflection from the e-prep, and it was about taking responsibility and working in life and how that helps us progress. And it shared the example of how some sharks have to keep moving or else they'll die. So I kind of just said how kind of what I got from that, it's our like duty to keep moving forward and progress upward in our life. And that I was thinking about holidays and times off from school and work, how I'm kind of lazy sometimes, and after a while that kind of gets pointless, and I just feel like I need to do something, and so making a plan kind of helps with that. And I said how going into the nursing field, I'll be able to constantly grow and move forward as healthcare is changing, so that there's always going to be something new, and we're always going to have to learn more, and so that will just kind of help our brains and our thoughts and our practices grow in life. And I know that Heavenly Father wants us to do that as kind of a purpose. Going back to the devotional earlier this week from the president from ASU, he talked about how we have so much potential and that we're carrying around the most complex thing in the universe, which is our brain, and how we just need to keep working with that and unlock different things from there. And I say that in the name of Jesus Christ, amen. Our dear Heavenly Father, we're so grateful for all of our blessings, and we're grateful that we can be here in class today to learn about different things about healthcare and help us to continue to prepare to become professional nurses at the end of this semester and after taking that in class. Help us with all of our planning that we may know how to go about seeking what we need. And please bless Sister Forbish as she teaches a lesson today, and we're grateful for her thoughts. And we love thee and we say these things in Jesus Christ. Amen.
Thank you so much. So today's class really is kind of a fun one. There's so many things that we need to go over, and as I read over your e-preps, I was happy to see that all of you liked our scripture reflection. And just yesterday I was in a meeting where I found some really interesting things that's kind of cool. Our scripture reflection is from the Self-Reliance website on LDS.org, which I'm sure you all know. And I had a really fun experience. I got to be one of the first facilitators for a trial group in the United States. The Self-Reliance program has been worldwide, going on for a number of years, and it's just coming to the United States recently. And it's to help people either do, let's see, there's a number of different groups. There is get an education, get a job, start a business. Ooh, and there's one more. I don't know what it was. Anybody see that on the website? Anyway, so yeah, it'll come back to me. But it's really cool. It's an amazing program. And I just found out in this meeting yesterday that the Self-Reliance Services and Pathway Worldwide are absolutely interconnected. And so the programs that they choose for Pathway Worldwide also will have the same goals and outcomes as Self-Reliance Services. So that was kind of an interesting thing, how everything, I think it was just a testimony to me that the Lord sees the big picture and he gives us a piece here and a piece there until we're ready to accept it and learn about it. And then it all just comes together. And I bet sometimes it's really hard for him to be patient with us. And can people see? Like, although I'm sure, he's patient, he knows us better than we know ourselves. So to me, it was just another one of those testimonies that everything is coming together in an orderly fashion, and the Lord has it. And so we just have to learn and pick it up as we go. And there's so many things that as nurses we can do to help and move the world as I went through and saw how you ranked the outcomes, overall, number B, how the healthcare system changes are affecting nursing was your top priority. That one was the one that the majority of you ranked as number one. And then the other two were kind of split. There was a few more that ranked C higher, describe how efforts to maintain satisfaction and contain costs are changing to today's healthcare industry. And then compare and contrast today's healthcare system with that of the recent past. Seemed to be pretty much the lowest one. So I'm going to go backwards and start with that one. We'll just spend a couple minutes on it. Why does the past matter? Why is it important to understand what happened in the past in healthcare or in anything? Why does it matter if we understand what happened in the past? Yes.
So we can learn from the past. I mean, that's, I feel, is the most important thing.
Yes, we don't make the same mistakes again. Right. Okay, good. That's the one point that I really wanted to bring out about that. There's a lot of things that happened in the past that we don't care about, but it's good to know it and understand it and not repeat the same mistakes.
Yeah.
Okay, great. Most of you did really, really great with your definitions. The budgeting process, let's take just a couple minutes with that though. Where does the budgeting process actually start? Who initiates a budget for any kind of a healthcare facility? Have any idea? Or I guess who's ultimately responsible for the budget? Okay, administration. And actually there's even one step up from administration. It's the board of trustees, or it depends on if they're for-profit. It'd be like the corporate headquarters, the board of trustees, then the administrative body, specifically the chief financial officer, the CFO, you'll hear that term, will be the person ultimately responsible for all financial matters in a healthcare facility. And then it'll go down to like directors, managers, and then all staff, everybody who works has responsibility for that budget, don't they? Okay. Any questions about budgeting? My least favorite thing was budgeting, not fun. Okay, so we'll just skip right over that. How about DRGs? Did anybody have any questions about DRGs? Most of your definitions were pretty good. And this is one of those things that kind of has been around a long time. This came into effect back in the 90s. And so what does DRG stand for? Great, diagnosis-related groups. And so this has been a way that hospitals have been paid for providing patient care. A diagnosis-related group, what might be a diagnosis that would be a DRG that you'd see in a hospital? It actually was started by Medicare. So a Medicare patient should be throughout, how about a total hip replacement? A Medicare patient comes in for a total hip replacement. So that's their main DRG that they get paid for in that hospital stay. But if they also have diabetes, hypertension, kidney disease, those are comorbidities. And so those can be added on to, but they're going to get paid under that DRG of a total hip replacement. But if the DRG for a total hip replacement says they can be in the hospital for 2 days, and they have these other comorbidities, they may be able to attach those comorbidities to their bill, and they may get 3 or 4 days. And so that's what they get paid for. If the patient ends up staying in the hospital 7 days, they get paid 3 or 4 days, whatever that DRG said they get paid for. So that's one of the things to understand about DRGs. Even with, wow, okay, I try not to say Obamacare, but what's the real word?
Affordable health.
Thank you. All of a sudden it just left me. Yeah, with the Affordable Health Care Plan, which may or may not be going away in the immediate future. We don't know yet, so we're kind of in that tenuous situation. DRGs still apply, and I expect that they will be, no matter what our new healthcare system comes to be. Any questions about DRGs?
So that way, like, if somebody's in for total hip replacement, you just wanna get them out by the date that they should be out, and if they stay longer, it will end up costing the hospital.
That's right, the hospital absolutely will have to write off any extra, they only get paid a certain amount. And in fact, it may be that, in that area, for that size of hospital, for the expected costs, the Centers for Medicare and Medicaid Services, CMS, have contracted with that hospital that they will be paid, let's say, $1,800 for a total hip replacement. And then if they have those comorbidities, they can add those onto the bill, so they may get it up to $2,300 that they could get paid for that particular patient. If the patient has a complication, a hospital-acquired infection, or a fall, anything like that, and ends up staying longer, they still only get paid the $2,300. They will not get paid anymore, even if their costs add up to $6,000. Their reimbursement still $2,300. So then that's okay. So just one of the things, Mountain View Hospital, a fabulous hospital. It's great. It's owned by physicians, very smart physicians who opened it. It's a specialty hospital. And one of the things there was, when it got open, there was like great big controversy about that they were taking like the cream of the crop and that they would choose the patients that would go there. And to an extent, that appears to be somewhat true. Usually the younger, healthier patients. Yes, Lindsay?
There's actually, so I'm at the Mountain View Labor and Delivery. There's actually quite a bit of controversy now with the doctors there. There's one pediatrician who he is at Mountain View, and he started this whole education where he teaches a class every month. He offered it at ERMAC, said, I can teach it here if you want me to. They said, no, we don't want anything to do with it. So he's like, okay. So he goes, then he does this at Mountain View. Well, then they start seeing that all the patients start going to him instead. So now ERMAC's like, we're going to take the class, but we're going to have our doctors teach it. And they just took the class right from underneath them. And now like other doctors at Mountain View are getting involved. And it's this big mess now because of that.
Thank you for sharing that. Okay, this is really like the politics of healthcare. This is, so certain hospitals, when they first opened, there was kind of a big fight. They tried to block them from opening, saying they weren't really a hospital, they don't have an emergency department. And then there's, all the fights, this is part of understanding healthcare systems, which is why I'm going into this, just so that you understand when you go to work in certain places, some of the undertones that you might see. Hospitals have to have contracts with different insurance companies. For instance, DMBA, which is the insurance company for employees of the church. Everybody who works at BYU-Idaho, BYU, church employees worldwide have Deseret Mutual as their insurance company. When Mountain View first came in, like ERMAC and Madison tied up the contracts with DMBA, so Mountain View could not be, you can only have a certain amount of primary providers, healthcare providers in an area. So ERMAC and Madison are the primary providers for DMBA. So if a person with DMBA goes to Mountain View, they get reimbursed, they get paid at a lower rate. For instance, I have DMBA, if I go to ERMAC or Madison, whatever my health care is, I get paid at 90%, they'll pay it at 90%. But if I go to Mountain View, I believe it's 60%. So that's, those are kind of healthcare system situations, and so there's always those things going on. Blue Cross recently, Mountain View got the Blue Cross primary care provider, which was a big coup for them too. So they get paid, reimbursed at a higher rate, so they get more Blue Cross patients than ERMAC or Madison. So those are, just interesting things just to be aware of, and we'll move on from that really quickly. So what's a full-time equivalent? As an RN, what kind of shifts will you be working most likely?
12.
12-hour shifts. How many shifts a week would you need to work to be working full-time? 3. Most healthcare facilities are 3. Occasionally you'll run into one that will say you gotta work 4 one week, 3 one week. So that's unusual. Most in our area anyway are 3 a week constitutes full-time, which is 36 hours a week, right? Generally, when on a regular business model, full-time is 40 hours a week, which adds up 52 weeks a year, 2,080 hours a year. And so there are still some healthcare facilities across the nation that have their calculations to ensure that RNs get up to the 2,080 hours a year. And so watch that really close, just kind of be aware of that. Most of them though, especially now, since we're in a nursing shortage again, it's going to be pretty much 3 shifts a week.
So some of the hospitals that I've been applying to in California,
Yes.
they follow the 40 hours.
Ah,
And so they require that you get not 40 hours in a week. Typically, most people hit it anyways, because if you stay and have to chart, and you never get off like right at 12 hours anyways. But they pay you overtime. So anything over 36 hours is still overtime, but they still require you to get 40 hours. And that's kind of one of their small ways of dealing with the nursing shortage is because legally they can require everyone to work 40 hours, and so they do, but then they pay you overtime for anything over 36.
okay, great. And so they probably don't require the 40 hours in a week, but perhaps
No,
80 hours
the total in the
a
year. Total.
Yeah,
So
and
usually in a
total into
month,
the year.
you'll just pick up an extra shift in the month, or they'll have a shift like a 6-hour shift where you just come and like relieve nurses for their lunch, and then you leave, and you just do that once a month.
Great, thank you for sharing that. That's perfect. Those are the kind of things that you're going to run into as you go to different states. Okay, great. So we kind of talked about the prospective payment system already. Prospective payment system actually is tied directly into DRGs. So it's basically just says that for certain diagnoses, you get paid a certain amount. Okay, what's a critical pathway? I saw you guys all have definitions in there for critical pathways.
Keeping to standards, the standard of care for a person. If a person comes in with a certain illness, then you follow a certain order of how to take care of them. And then you make deviations according to how the patient is receiving treatment.
Perfect, that's very well said, Alex. So it's an algorithm. As you did CPR, when you renewed your CPR, they had a specific algorithm or a pathway of what to do to take care of a person that was in either cardiac or respiratory arrest, right? And so that's a critical pathway. As you take more classes like ACLS or PALS, they will all have like a critical pathway, an algorithm of how to care for a specific patient. On many units, especially in intensive care units, NICUs, you're going to have critical pathways or a clinical algorithm that says if a patient comes in with this, this is what we do. And so it's got that step-by-step process of how to care for that specific patient.
Is it like protocol?
It would be like a specific protocol for a certain diagnosis, the way that we treat this patient. And why would we want to do that? Why are those useful or important?
Like you wouldn't be paying for random things on different patients. It would just be very standardized.
That's exactly it. It's a very standardized procedure. And it kind of goes back to what we talked about last week a little bit with the evidence-based practice. These critical pathways or algorithms have all been developed on the basis of evidence-based practice. And so what works best? What's the best clear way to provide care for a specific patient? Yes.
I have a question. So on the prospective payment system, if I understand it, it's like they get paid for what they agreed on, kind of. But so what if it ends up being, the cost ends up being less? Does
They still get it.
Oh, really?
That's right. Yes. So if they provide good care and that patient gets to go home early, they still get the full amount. So that's how that balances out when we have the other patient that we talked about, like with the total hip and all the comorbidities, and they take longer. Hopefully they get enough of the other younger, healthier patients that recover well and go home early to kind of balance that out. Yes, Ryan?
How long has this type of system been in place for?
I would have to look that up for sure. It was in the 90s that.
So were you practicing when it went in?
Yeah.
Did you see a negative effect or a positive effect on the healthcare system?
You know, anytime there's a change, people kind of get excited and worried about it. I remember actually when the prospective payment system was initiated, and I remember hospital administrations all over just being nervous and worried that hospitals were going to go out of business, that our healthcare system was going to implode, that, you know, we wouldn't be able to be profitable and, you know, wouldn't be able to provide patients care. But then it kind of forces organizations to be more efficient and to figure out ways to provide better care for patients, thus the critical pathways
Yeah.
and those kinds of things.
Do you think that it also could drive up the cost of healthcare? Because
Absolutely.
if they're saying that they're only going to pay you for 2 days for a hip replacement, but the doctor knows that it's going to take 3 days, or the hospital knows it's going to take really 3 days, so they just make the cost of the hip replacement surgery more expensive to compensate for the extra day that the patient's going to have to stay there.
They're not going to get paid more because they decide the cost is more.
Oh, so it's a flat amount?
It is. The hospital could bill as much as they wanted, but what they've contracted with CMS, that is what they're going to get paid.
Okay.
So it really, quite honestly, and if it's a Medicare patient, they have to take what Medicare pays. The patient has their deductible amount, whatever that may be, whether it's $160 or whatever that is. But so the hospital will be reimbursed for the lump sum that CMS pays them and the patient's deductible and no Medicare.
Would there be, since more people, maybe people who didn't qualify for healthcare, couldn't afford healthcare before, now can, so did you see like an influx of patients when they started implementing it, or like more people getting healthcare because now they can afford it? Like maybe someone was avoiding getting a hip replacement because they couldn't afford it,
Absolutely.
but then now they're covered and so they do, and so was there like a high influx of that?
You know, and truthfully, I've been in southeastern Idaho.
Oh, okay.
And so we really we don't have a high percentage of non-insured patients. I have a really good friend who lives in southern Texas and was a CNO in a hospital in South Texas. And at the time that she worked there, their uninsured population was over 50%. They had a very high percentage of immigrants, whether they were legal or not, and so their uninsured population was very, very high. So with the Affordable Care Act, it changed their dynamics tremendously. Here in southeastern Idaho, I believe it did make some change to ours, and it also made it so that some people who were not able to qualify for Medicaid, some of the programs that came along with that, there's a program called CHIPS that is part of Medicaid. It's the Children's Health Insurance Program that helped mandate so that children would have access to health care. And so those were some of the things probably that had a more impact in the Western United States that provided health care to more patients. Did I answer your question?
Yeah.
Kind of went around.
That's good.
It is very complicated. And like we said, with the upcoming changes, it hasn't even been released yet, so nobody really knows what the potential is to change it. Yes, Alex?
Has it been accepted yet?
I don't believe so. Yeah, I think it's
It's
still.
hardly been unveiled, yeah,
What's that?
it's hardly been unveiled.
Yes. Yeah, there's only been tiny pieces of it that are even public, even the public even has access to, so knowing what it is really hard. All right, I saw some great definitions for patient-focused care. Any questions about that? I think you guys did really well on that. So the staff mix, what kind of staff mixes do you see where you're doing your preceptorships? What kind of other personnel do you work with? Yes.
I was in the ICU at Bingham, so it's a lot smaller.
Oh, yeah.
Often on the floor, there's only one nurse, and so it's kind of hard because we have to call someone from a different department to come down to verify insulin or any narcotics, as well as the CNA is not really a typical CNA. She's more of, I think it's called the Hulk in a regular hospital that looks at she looks at all of the EKGs for all the floors, and not just ICU.
Okay, so she's a tech of some type. Okay, very interesting. So mostly an RN with a tech. Thank you. That's, yeah, a lot of responsibility. You have to, sometimes in these smaller facilities, the RNs are really on your own a lot, aren't you? Yeah. Thank you for sharing that. Okay, what else are you seeing? What are the other types of staff mix that you're seeing? Even, okay, so Bingham is different. Who's at Madison? Okay, what staff mix do you see at Madison?
So I'm in the ICU, but I didn't realize the ICU and the med surg floor are like very much connected. That was kind of weird to me, because I always thought ICU was like, you need to wash your hands before you go in and all that kind of stuff. Like, anyway, so there's lots of nurses around. I didn't realize that LPNs could like have a patient load. I didn't realize that before I went there, but there's LPNs that are working. They can't like give certain medications and stuff. They have to have someone, an RN do that, but they have a patient load.
Okay, great. So you're working side by side with LPNs who also have their own patients. Okay. Well, who's at ERMAC? What kind of staff mix? Okay.
I'm in the ICU, so it's unique in that there is no CNAs. There's no. ERMAC actually doesn't have. They have a very few amount of LPNs, but by the end of the year they have to be an RN, otherwise they're not going to have a job at ERMAC anymore. But so it's just RNs, pretty much in the ICU at least.
Okay. Thank you for sharing that too. So they've been mandated. That's a corporate mandate that they will no longer be employing LPNs in their hospital. So, yes.
In the OR at Urban, they have surgical techs, and then they have RNs, but then they also have like RNs that have done like certified programs, and so there's CRNAs, there's one CNRFA, which is like
First assist.
something like that. He
Yeah.
can scrub in, he can help surgeons with surgeries, and then there's several other like chief nursing officers that can scrub in as well. So I've been trying to figure out all the different levels of RN that you can be. There's a lot.
So those are the CRNA, they're the nurse anesthetists, and so that's an advanced practice degree. And the FA, it's a first assist, which there used to be two ways. I should have looked this up first. I hadn't looked it up recently. There used to be two different ways you could get to be a first assist. You used to be able to do it with a bachelor's degree and obtain a certificate. It may be only a master's degree now. Do you know?
I don't know.
Okay, sorry, I should have looked that up before I brought that up. Didn't anticipate that coming up today.
I just noticed that he took like a separate board, and he said it was like the NCLEX on steroids. Like he said it was so hard.
Yes.
so hard.
Yeah. So,
I don't know exactly
so
what
it may
was on,
either be a master's degree or it may be a certificate program, but they do have to be certified in it. They have to, test and have practicum hours and cool job though. Yeah. Had a friend who was a first assist for a neurosurgeon and he loved it. It was, so often the first assist will work specifically with their physician and they get to know what that physician likes. And so that's the great thing about nursing is there's so many different things we can do. So many opportunities. If you find you don't like where you are, there's plenty of other things within nursing that you can figure out that you will love to do. Okay, mandatory overtime. Ryan talked a little bit about that in, when he was applying for jobs in California, how they do require the 2,080 hours per year. And so anything over 40 hours a week, they do pay overtime. But sometimes in order to get that mix, they do have to work overtime. What other times might you see mandatory overtime? Yes, Alex?
Well, my wife worked for Teton Post Acute, and they have a huge turnover. So they get new nurses all the time, and they work their nurses really hard. And so before my wife quit that job, one of the nurses had worked over 60 hours that week, and she was coming in the next week to work that many or more hours. And so it was just kind of ridiculous to think about that. They came in, they worked, they went home, they went to sleep. They were getting ridiculous amounts of overtime pay. So I'm sure they were making well into six figures.
Oh, yes.
But it was just really hard on the nurses.
Yeah.
At ERMAC, they have a policy. I think it's called a Code 66, and they'll like text it to you, and that means that all available people need to try to come to the hospital because they're at a critically low staff or critically high patient load. So then that's mandatory.
Great, thank you for sharing that. Yes.
Aren't they looking to pass a bill too that will like kind of keep that regulated about how much they can work?
Some states already have passed legislation that do regulate that. I know back east there are a number of states, Virginia, okay, there's a number of them, I won't even start listing them. And I think California may be one as well. Okay.
Yeah,
yes,
so
you
they
saw
can't
that.
force you to work. So the law is 40 hours, so that's where that thing, they can force you to work 40 hours or require you to.
But no more.
But they can't ask you. They allow you to work up to 60 hours though, if
Okay.
you volunteer.
If you volunteer to, but you cannot be forced to. Great, great. Do you know if that law has any exceptions for emergency situations like the Code 66?
I have no idea. I don't know about that.
Okay, yeah, because there are times that, okay, for instance, one of the things that I know that's happening in our area, the end of August, have any of you heard about what's happening the last week of August? Yeah, so there's going to be this eclipse,
Oh, yeah.
and the predictions are that there's gonna be like 60,000 plus visitors in our small community.
Someone rented Manambu, I heard.
What's that?
Some Oriental family rented Manambu.
Actually,
It's word on the street.
okay.
My English teacher's renting out his house.
Word on the street
6
is
nights.
that there's a group from Japan that rented out Grand Target
You
as
just
well.
gotta stay there.
So how is this going to impact our local healthcare facilities? They're gonna be overloaded. Do you think that any nurses can request
No.
vacation that week?
No.
No. Yeah.
So
How do you think that they're predicting to staff for that week?
Everyone.
Everybody, that's right. Every available person is going to be at work that week. Yes, Anna?
You know what's funny though is they're also switching at Madison their charting system like the week before. They're switching it to Cerner or something like that.
Yes.
It's like the week before, and I'm like, well, that sucks. I'm glad I won't be.
Yeah, that's gonna be wild, isn't it? Yes, at least it'll be done. Hopefully it does go smoothly, because that's gonna be a very busy time. Okay, great. Okay. Oh, so that, we went right into staffing plan. That was one of the things I wanted to bring up about staffing plan. Yeah. Other things, what other things affect the staffing plan? On the different, several of you mentioned that you work in ICU. How is an ICU generally staffed? Nurse to patient ratio.
1 nurse to 2 patients.
Okay, usually 1 or 2 patients per nurse, depending on their acuity. Okay, good. Yes.
I was gonna say, like, at Mountain View, they have like the acuity numbers and they put a number next to each patient.
Okay.
And then each nurse can only have. They usually try not to go above 6, but it's up to you.
Okay, great, great. So that's exactly, yeah, depending on the type of patient you're caring for, your load can be 1-on-1 or 1 to 6. Occasionally on med-surg units. Is there a difference in patient load between day shift and night shift ever? Have you noticed that? Yeah, so what have you seen as far as that goes? Yes, yeah. And why?
Just because there's less nurses for the night shift.
And actually, the rationale would be that generally the physicians aren't making rounds. You're not recovering new surgeries, hopefully, and things are more stable on night. That is kind of a rationale that's been used. It's not always the case though, right? But it is frequent practice that nurse-patient ratios will be higher on night shift. Okay. And what nurses are generally working night shift?
The newbies.
Yeah.
Although there are nurses that just love night shift and will work night shift for many, many years. So they're very valuable, the ones that like to stay there and help out.
As long as you don't have to wake up the school.
Exactly. Okay, that really is a hard thing, shifting back and forth, isn't it? Yeah. Yeah. I used to know a husband and wife who were both nurses, and they both worked night shift, and they actually homeschooled their children, and their whole life revolved around night shift. They trained their children from the time they were little that they would stay up late, sleep in late, and they adjusted their whole life to night shift. I know, I didn't get it. I worked nights for many years and never adjusted. Okay, so, what kind of things did you guys decide were a good responsibility of nurses to help with budgeting, to help with the overall budget? What kinds of things can nurses do to help with the overall budget? Yes.
I think we can help to prevent risks like preventing ulcers or preventing falls, because that's gonna keep the patients there longer. And like we were saying, insurance is only gonna pay for a certain period of time. So if they end up staying because we didn't help prevent an ulcer, then that's gonna cost the hospital money.
Right, that's great. Excellent.
I think trying to make sure that you're not using too much supplies, but that you're using enough at the same time. Like, don't short them so that you're not giving them the right care, but don't overload the supplies.
Perfect. Yes, those really add up, all those little things, don't they? Tremendously. I know if you ever go into a patient's room and you see like all these dressing change supplies on the counter and things that you know are just going to be wasted. Yeah, that costs the hospital a lot of money, doesn't it? Okay, good. And how about being efficient in what you're doing? I think one of the struggles that most new nurses have is being able to provide all the care and keep up with your documentation. Has that been a struggle for anybody so far?
I had one instance where that was a struggle. My preceptor, one of my goals was to actually just take a full shift load, and so he kind of stepped back and let me handle things. He'd step in if I was getting overwhelmed. And one of the things was I was very slow with my charting just because I was still trying to figure out. I was getting faster, but I was still pretty slow. And so I was in the room charting as much as I could about the assessment that we just completed, and it was taking too long to where it was pushing back the assessment that we needed to do on the other patient. So that was one thing that he told me to focus on, is just to remember that you can always chart, you can always stay late to chart, but just make sure that you're taking care of your patients first and not worrying about the charting.
Okay, I'm going to contradict your preceptor a little bit.
So
in the beginning, you're probably going to be okay to stay late to chart. But what if this becomes a pattern?
well, you'll get in trouble if you're staying later all the time.
You
but,
will.
Yeah.
Yeah, okay, good, good. Thank you for bringing that up. That's exactly what I was getting at.
Yeah.
Great example. And that is, and as you get more experience, and that'll be one of the things to focus on, that you'll become more efficient in both your patient care and your documentation. So you'll be able to do things more quickly and more efficiently. Great. So one of the things, it talks about age caps, and it talks about the way that we can find out if the hospitals that we're working at are providing good care. So what do they ask? What is age caps?
Oh.
Yes.
Isn't it how the hospital gets paid based on the patient's, what the patient says, or the patient's review, their experience?
So it is patient satisfaction, isn't it? And yes, that does reflect back on the hospital's reimbursement, whether or not their patient satisfaction is good or not. Do you know how that patient satisfaction is gathered? How's that information gathered?
Just surveys, like, if you understand.
Okay.
Surveys.
Yeah, there's a survey. How can the survey be administered? How does the patient get the survey? There's actually several ways. Yes, Alex and Alan.
My wife and I have gotten phone calls before, so.
Did you answer it?
Well, when we do answer it, if we're not busy, then we're honest.
Okay, good. No, that's absolutely important that you're honest about it. Yes. Yeah, okay, perfect. Alan?
I know on 4th floor on Ermac, the nursing supervisor goes around and asks the patients about like how their care was given, about the nurses and other things like that.
Every shift.
Okay. And that's good. That will be an internal process. That is not reportable HCAHPS data because it has to be administered by an outside entity. Yes.
So they try to do follow-up phone calls, so they have something at RMAC. I can't remember what they're called, but they're actually RNs that do follow-up phone calls to see if the patients had kept their appointments that they scheduled while they're in the hospital and been doing their medications and picked up their prescriptions. And when they do that phone call at the end, then they try to get them to do the survey over the phone.
Okay, great. And so they probably, at the end, they transfer it to someone else.
Yeah, I don't know how they do
Okay.
it, but I just know that's what they try to.
There's a lot of internal quality improvement surveys that all healthcare facilities do, but HCAHPS data has to be gathered by an outside entity because it has to be unbiased. Yes, exactly. So I know I recently received a phone call to ask me the HCAHPS survey questions, and I looked at my phone, I didn't recognize the number, and I didn't answer it. And but they did leave me a message and said they'd try to call back later. So, yes, so that also brings me back to the point that the data may not be, it's hard to gather the data, and a low percentage of people actually get surveyed. Yes.
Well, I mean, like a lot of people, usually when people have like a review or something, it's usually because it's negative. And
Yes.
so it's often skewed because only the people that are truly passionate about how they've been treated. And I mean, like if someone's treated well, they're like, oh yeah, they'll say it by word of mouth. But they won't just like, you're like, oh, they did so good, I'm gonna call them up and like tell them how they did.
Right. And everything was just fine. There wasn't a problem. You just go on your way, everything's fine.
Yeah.
So unless it was it was bad, you're gonna tell everybody. Or if it was wonderful, you might tell people. But you're right, more likely the bad
You
experience.
treat the thorn in your side.
Yeah, good. So do you know what questions they're asking about nurses? What they're asking, that they'll ask the patient, how often were you treated with courtesy and respect? And how often did you clearly understand and did the nurses explain what they were doing? So it's about communication and treating with care and respect. And the answers that the patient can give are never, sometimes, usually, or always. And so that's when you see the managers going around and doing those questionnaires to the patient, I want you to listen to what they're saying. And you're going to hear them saying, did the nurse always treat you with kindness and respect or with courtesy and respect? Did they always wash their hands? Did they always explain your medications to you? Those are the things that, and it's actually, to try and get that in the patient's head because makes a huge difference. If they say usually, it doesn't count nearly as much as always. They want the patients to answer always.
So I worked at the Phone Center, and I gave hospital surveys.
Oh, cool.
And so, yeah, with the nurses, they ask like, how often did they respond to the call? Like, were they quiet at night? Like,
Yeah.
So just,
That's
was
HCAP
your
survey.
room kept clean? Like, it's
Yeah.
all of it. And they're so long. The surveys are really long.
That is the HCAP survey. Those are the HCAP's questions.
Yeah.
Yeah. Very cool. So you know what the questions are.
Ain't nobody got time for
Oh, yeah.
I'm watching.
So I want to just quickly show you the hospital compare website. And I went ahead and pulled this up. On Hospital Compare, wherever you go, if you're looking to work at a certain hospital in another state and you want to find out if it's a good hospital, you can go on Hospital Compare. And in fact, if you're choosing between 3 hospitals that you're applying to, you want to know what they are, you can look it up by state, city, zip code. And so I just pulled up 3 from our area. I pulled up Ermac, Madison, and Portland. And they have, and I'm right now on the survey of patient experiences. So this is results of their high HCAP scores. And so the different things, let's see, we'll go there. Let's see.
Ermac is the left.
Oh, yeah. Okay, so that's, yeah, it's Ermac, Madison, and Portland. Yeah. Ermac, Madison, Portland. There you go. Okay, you can see that. So they have overall ratings, and they have then specific items that they're surveyed on. And so it is patients reported that their nurses always communicated well, pretty close to the same. Oh, and then the last 2 columns are Idaho average and national average. So there's a lot of healthcare facilities are doing lots of their own surveys to prep their patients for these HCAP surveys. So the data there is patient reported that their doctors always communicated well.
Patients reported
That they always receive help as soon as they want it. So you can see that they only get counted if they choose the always option. Okay. Patients reported that their pain was always well controlled. Can post-op pain always be controlled? Maybe not, but well controlled, yeah. That one's going away. Patients reported that the staff always explained about their medications before giving them to them. That their room and back rooms were always clean. That the area around their room at night was always quiet.
That's impossible.
Patients reported that yes, they were given information about what to do during their recovery at home. And then patients strongly agreed that they understood their care when they left the hospital. Patients who gave the hospital a rating of 9 to 10 on a 0 to 10 scale. And patients reported that yes, they would definitely recommend the hospital. So that's the HCAP survey on Hospital Compare there. Or, you know, it doesn't all fit on the screen. But I thought you might find that interesting and know that if you're, you know, going to a facility as a patient or going there to work as a nurse, there's a whole lot of data that you can look at on that website and compare different things. Yes.
So this makes me think of, they have a rating for efficiency for doctors on mortality and morbidity.
Yeah.
And the doctors that have a higher specialty usually get a lot lower scores, even though they're the best in their field at that thing.
Right.
So while looking at this, Ermac had a lot of lower values most of the time. And so it's like, well, are they better or more proficient, but they just get worse patients? Or is it just because people don't like it?
That's why you have to look at a wide range of data, because these hospitals are not apples to apples, are they? And I specifically did not include Mountain View And that's why I went to Portna rather than Mountain View, even though that's in Pocatello, because it's, Madison's by far a smaller facility. They don't do like in-house cardiac surgery, you know, those kinds of acute things that you do see at both Ermac and Portna. So you do have to look at a whole wide range of the data to figure out what it is that you're looking at. Because of that, there are different things. In fact, like there's some that have to do with specifically a patient coming into the ER and what happened to that. If there was only one patient that came in with that specific, for instance, they came in cardiac arrest and the specific protocol was not followed, and there was one patient, their survey could be absolutely in the toilet, where if there was 30 that came into Ermac and one wasn't right, theirs could be 90%. See what I'm saying? So the data can be skewed according to what care is provided in that facility. So that's why you need to take a broad look at it and look at a myriad of different things. That's why I just went over those specific. I thought these would be the ones that would be most interesting to you as nurses. And so up at the top, you can see there's lots of different types of data you can look at. There's, timely and effective care. Oh, and complications, that's the one that I said if there was one specific patient that came in, okay, I must have gotten lost. Oh, surgical complications, here we go. Go with surgical complications. See, that could, or deaths. Okay, there you go. Okay, that actually, see, Madison says the number of cases too small, and the other two say no different than the national rate. So that kind of brings that up to that situation. And then say you can look at like healthcare acquired infections. So that one doesn't have a lot of data. It's either not available or no different than the national rate. So, but there's lots of interesting things that you can go in and look at. And everything is publicly reportable. That's the other thing. If there's an adverse event, it's publicly reportable and anybody can look at it. But the one thing is that this is after that. Please come in. Okay. So I would like to introduce Dr. Rachel Gonzalez. She's the CEO at Madison Memorial and a good friend. She's an amazing example.
I'm grabbing glasses.
Okay, great. Okay, nursing leadership. She's a registered nurse who has her PhD, and I actually asked Michelle for information so I remember for sure what your PhD was, and then I have it buried here someplace.
Okay. I can tell.
Okay, I will turn the time over to Rachel and let her tell you the rest, and we're very excited to have you here today.
Okay, remind me of time.
We have an hour. We get done at, at 12:15.
12:15.
Yes.
Okay, all right, if I get like too talky.
Okay, I'll let you know.
High five sign.
Yes.
Morning.
Oh, and just so that you know, we are being recorded.
Oh, cool.
Our students, some of our students are in other states, and some of them are doing preceptorships at night, and they even be in preceptorship today.
Okay.
So we record our class as well.
Can they call in and ask questions?
They can't. We're trying to get it so that it does work that way, but it hasn't been working yet.
You can answer the questions later.
Okay.
Oh, good morning.
Morning.
Okay, so remind me, this is your nursing, what class is this? Capstone course, so what does that mean to you guys?
The last one.
Okay, what else?
It's the cherry on top.
The cherry on top. I like that. Good one. What else? What would your teacher say to this?
It's where we implement all our skills into one area.
Okay, all right. Anything else? Leadership. Okay. And
one thing that she asked me to come and talk about, but I've had fun teaching in nursing and in business and from the undergraduate to the doctoral level. And so it's been fun and you know, she may not share this with you, but the part that's cool is you get to learn as much as you get to teach. And so she may not share that too much with you, but she's learning the whole time. So I'm gonna go through a few principles because she shares your course objectives with me. But I think it would be helpful, that's why I was asking if they can ask questions, if we spend a fair amount of time where we could just talk, because you know, we're living and breathing this, and we get the opportunity. She serves on our board. Did you guys know that? She's technically my boss. Isn't that kind of cool? Yeah, I'm nervous. Yeah, she's a board of trustees for the hospital, and she's a valued asset for that. You also have Dr. Corey Rammel. You know him from the health center. He's also a new board member for the hospital. So it's very nice to have the relationship, having the clinical piece as well as having the relationship with the college. Yes?
So, how many people are on the board and how did they get there? Because, I mean, we've found out nice little tidbits of Sister Forbush's success of owning a nursing home, and now she's on a board of the hospital. Home health agency, sorry, and the board. So, I mean, is this a business standpoint that you buy into, or do you work up a ladder of?
Actually, it depends on the hospital. Sometimes it is a business standpoint. So if you're for a for-profit organization, hospitals, then sometimes they are on the board because of a business venture. Ours is a county hospital, so it's technically owned by the people of Madison County. And so it's her skill set, her current role that gave Sister Forbush the role she's in, and the same thing with Dr. Rammel. So the county commissioners, do you know who they are? They're kind of overseeing our whole county and the operations. They appoint the board. They'll take recommendations from the 9-member board that we've got now, and we look at different skill sets, different type of businesses. We've got a lawyer, we've got business owners, we've got just a diversity. You want diversity in age, you want diversity in males and females, you want lots of diversity because guess what? That's what the organization is, right? And so the same thing as far as the backgrounds that come to the board. You want different people that can speak to it differently and represent that whole organization. That answer your question?
It did.
Yeah.
Do they make decisions about the hospital? Like, or what does the board actually do?
Their number one job is making me happy. Their job is governance. So, anybody know what that means? No? Okay. So, can I write in your board?
You bet.
Okay. And if I get a little too far off and you want me to go back, you let me know, but what they're interested in. So hospitals were set up a long time ago. If you think about our governmental system with checks and balances, okay? So you've got if you think of our judicial system, we've got our checks and balances. So we've got our, anyways. We've got our commissioners, okay? And you've got our board of, I write like a real clinician, so you can't read it. So the commissioners, county commissioners appoint the 9-member board. And then below that, you've got two things. This is administration. So this is me as far as the CEO. And we've got a chief medical officer, a chief nursing officer, a chief operations officer. Financial. Oh yeah. Chief fund officer, chief financial officer. Gotcha. So the board's job, 2 priorities, is to look at the overall governance of the whole hospital, making sure that we're compliant with all the rules and regulations, and appointing the CEO and monitoring, making sure I'm kind of doing what I need to do, as well as appointing the medical staff. These two do not govern each other. They're separate because that's the checks and balances. So this is Dr. Rammel and all the physicians, and they govern themselves under this direction. So it means they look at it from a really big picture, the strategies. What should we do in everything from 3 months to 3 years to 5 years to 10 years, and making sure that's in alignment with the county and the goals of the county, with the people who live in Madison County in that area is want to meet. Okay? They do not, unless you're messing up as a hospital, unless I'm messing up the others, they do not do the operations. So they do not, Pauline, it doesn't.
You can call me Molly, it's absolutely
A lot
fine,
of
thank
years.
you. Yes.
I kind of get in that bad habit with the doctors too now, and so I try to remember, oh, Dr. Ren. But if the CEO or the administration is going off kilter, and we're starting to focus on our own personal agenda items, for example, then the board would need to make sure that we're staying in line with the strategic plan. That they wouldn't get into the day-to-day operations as far as hiring, firing, that kind of stuff. Does that answer your question? Okay. Other initial questions about that? It's really, really fortunate at our hospital. I'll tell you, we're in an interesting time with healthcare, as you probably heard, and we're lucky. We're one of the few remaining county-owned hospitals of our size in the nation. And so it's very lucky, and I have nothing against the big for-profits we were talking about, like URMAC, we work with them. We also are affiliated with the University of Utah. They're great, they help us be a lot better, and it's nice because we have the local control. Because these people know what you need, and know what your neighbors need, and the others need, whereas they may not know that in Tennessee or other places. So we're fortunate that way. Please.
So like the for-profit, they have a board that would be outside of the state or like just somewhere else that kind of doesn't really have to do with the area?
They have two. So they have one board that is local. They focus on quality, and they more of an advisory board. So when we go to board meeting, we talk about strategy. Okay, we want to do this next big thing. And then they help guide and make final decisions on that. When they're going to their local board, they're kind of bouncing ideas off of them and giving some feedback. But the big decisions from finances and those types of things, the strategy, are decided wherever their parent company is. A lot of those are in Tennessee. It's a great structure, it's just very different. They're just set up for different reasons. Did you have questions?
You want to ask her?
You have a question?
Oh yeah, what does Tennessee have to do with anything?
No, I actually, you know what, I have no idea why they all ended up in Nashville or started in Nashville, but HCA, Healthcare of America, and CHS, Community Health Systems, those are the two largest in the nation, and that's where their headquarters are. And they all kind of worked for each other at times, and I really, do you know?
No, that's a great question. I have no
That's a great
idea.
question. I don't know if they just started there, do you know?
Yeah, HCA actually, there were a lot of spin-offs, for example, Psychiatric Solutions, which owns most of the psychiatric hospitals in the United States, is also based out of, just outside of Nashville. I think it's Franklin, Tennessee, that most of them are from. And a lot of them are just, they're spin-offs from HCA.
Someone in HCA must have lived there a long time ago.
Oh, I think that initially the laws were favorable to, to corporations, kind of like New Jersey is now. There's a million corporations based out of New Jersey because they're very favorable towards them, and I think Tennessee was for a healthcare corporation.
You know, I bet they probably still are because even some of the newer companies, they move their headquarters there. That makes sense. Huh, great question. See, I told you we learn at the same time, didn't I? Other questions about this part of it?
How do the community members tell the committee or board what they want as a community? Like how do they know what we need or what we want?
I'm gonna let Polly answer that first. And then I'm gonna put the hospital's opinion on that. I think you should answer that. Board, this is the board members. speaking.
And so one of the reasons that, like Rachel said, that there's diversity and in the board members, there's, board members that are business owners and different things like that, is to represent a wide range of community members. And the board members live in the community, know the community patrons. And I really love this. She explained that board members do not get into the management at the hospital. We don't get into personnel matters. And that is probably one of the things out in the community that sometimes gets confusing. And occasionally, community members will come to board members and say things like, I really just don't like that director. Do you know what they're doing to those nurses on that unit? And things like that that are really not the board member's responsibility. Our responsibility is the overarching, it's the governance. It's that we need to have faith in the administration to know that we know that they're doing a good job, and those are the things that we keep track of.
Perfect. Okay. So it goes back to that question of how did they get on the board? And the county commissioners need to do a really good job of looking at the whole community and saying, okay, we've got someone that's helping us represent the college population, and knowing you guys, knowing what your desires and your needs and things like that. And so, and then the same thing from a business and saying, okay, she has this interaction on an ongoing basis, so that's her experience, and she's gonna bring that into the boardroom, and she's gonna help guide and make decisions based on that experience of her exposure to you guys. So that's how she represents, or the other board members represent. But when they're, and if I may, the board, so she as an individual person has no authority or responsibility. Well, she has responsibility, but she has no authority to be able to do anything. So a board, by definition, makes decisions as a group, as a majority of that group, it's called a quorum. And so individually, she has no authority. But when she's in the room with her peers, that's where the authority comes from. Does that make sense? Okay. More questions on this? It's a fun topic.
I'm just curious, is the board kind of like a volunteer, like, sort of position then?
Yeah. They get a dinner. They get to spend late nights with us, early mornings. Sometimes they do get breakfast too. Yeah. Yeah, it is completely voluntary. And again, that goes back to the county commissioner or the county structure. And those from the boards of like big business, they probably have some shares in the company and stuff, and that's a little bit different. But yep, it's a service role for her. Yeah. Yeah, sorry.
So you're the CEO
Yep.
at Madison, and you were a registered nurse?
Yep.
Can you mind,
Still am.
do you mind telling us how?
How I got there?
Yeah.
Well, I'll tell you, I'll go back just a little bit, and if I start to bore you, just tell me. So I was having fun being a stay-at-home mom, and I loved it, and honestly, I thought, well, I might be a teacher someday. That was kind of my goal. And I had a little boy who became ill. And it bugged me that they didn't know what was going on with him. And so it was a little strange, and so I went and was checking out books in the hospital, started reading the neurology books, was reading all of those books. When a physician came in and said, I think you should go to nursing school. I'm like, you know what, I don't like watching blood and guts on TV. That was my perspective. I'm like, those shows are not me, no. It's like, let me put it this way. Normal mothers don't check out pediatric neurology books for entertainment. I mean, it wasn't entertainment. He knew what I was doing. So I got into healthcare for kind of a very personal reason. And for me, it was wanting to take care of others, especially those that had gone through situations similar, because I think I can empathize with that situation. So I love nursing from that standpoint. It's a service organization or a profession that there's a lot of really great things that you can do in healthcare and in the nation. But in the end of the day, what we do at the hospital is pretty awesome. You can't replicate that. And so with that statement, I'm just going to give you a little soapbox. We have a lot of expectations for nurses because of that. You're choosing a very high, respected, honored profession. I'll get to your answer. or a question. So I ended up in home health and hospice and loved that and just kept asking a lot of questions of why people were doing things in such a silly way. I would look at it and I'm like, why are you doing this so hard? You don't need to make it so difficult. And asking those questions got me put into a director role. And I think that the opportunities, the doors just opened for me. I loved education, so I went on and got my master's in nursing administration and education because I wanted to teach. And the doors just continue to open and challenges. Ended up at Madison because of a lovely lady right over there. And we knew each other and she convinced me it was a great place to go. And so I started working at Madison as, let's see, I wasn't the COO. I was organizational development.
Oh, that's right. I was like, that's right.
I think it's COO, which is a whole other subject that we could talk about if you're interested in. Some other cool, fun thing to do. It really had to come with my desire to want to help people do things in an easier way because it seemed like we were making it too difficult. We continue to do that in healthcare. And then as far as the CEO role, I never really had the dream, oh, I'm going to grow up and be a CEO. The doors for me, just kind of opportunities presented itself, and I would ask questions of smart people around me and kind of ask those questions and say, well, what do you think? What do we need? And I thought I would just try it. And so, I'd love to say, oh, I've always wanted to be CEO. No, I played with my Barbie dolls and made them crash, and I would bandage them up. That's about as close as I could say that I came into wanting to be in healthcare.
But your PhD, tell them about your PhD.
So I got my doctorate in management, and I went outside of healthcare specifically because we tend to get into some group think. And so I got a doctorate in management so I could learn from those that were in other business fields on how do they run large organizations. And I do believe that, I think where she's going with that, it helped me understand that we could do things differently and to learn how to run organizations. That focus was in development in an organization, so you could look at how an organization, a hospital, is its own kind of animal, if you will, and you have to understand how all those parts move together. I mean, this gets really complicated as you go down. And then you added our left doctors, and they, add in some fun twists sometimes too. The hospital is made up of a lot of different businesses. So nursing and the patient care, you've got the billing aspect, very different business, right? If you even look at our cafeteria, that's a very different business than if you look at our emergency room, right? Materials management. Now hospitals like us, we own rehab centers, we own imaging centers, we own physician clinics. You get into insurance. You have so many different businesses underneath here that it becomes very complex. So learning the business in a different aspect from a doctorate helped me kind of look at that from a different perspective. Did that answer your question?
Yep.
Okay. Thank you. I would encourage you, wherever you want to go in this, make sure you're enjoying it. Healthcare is wonderful. You just have to remember why you're in healthcare. Because it is stressful. Because you're dealing with people's lives. So you just go back to the core pieces and say, okay, this is pretty cool. We're pretty blessed to be able to do this kind of stuff, right? It's kind of cool. Questions on this part of it? Okay, I'm going to dive into leadership a little bit. So, a really smart mentor of mine, when I first was the first director, and he is now over Shriners Children's Hospitals, and a great guy, and he taught me one principle. And he said, stay true to your values. Stay true to who you are throughout this whole process. You get into management and executives and all this kind of stuff, it gets confusing at times. And so he told me, stay true to these things. So I came up with two principles. One and Holly probably could even name these, I bet, it's been with me a long time. One is you are only as good as those around you. These are my leadership principles. You are only as good as those around you. And then the second one is maintain your integrity at all costs. So let's go back to the first one. And these will be different for you guys. And by the way, you're an absolute leader at the front line. So these principles you should start thinking about now, your values. Make sure that those personal values are in line with the organization you work with, because you will be expected to be a leader on the floor in any role. Okay, so the first value, principle, was you're only as good as those around you. Any thoughts on why would a leader, from what you've learned so far in your courses, in this course, why would I say that? No wrong answer on this. Please.
From personal experience, like in Washington, a lot of people just are not LDS. In high school, I grew up with a lot of kids that just, you know, they would go out and drink and smoke and things like that. And although I didn't participate in that, I mean, just some of the other habits, and it's just difficult not to like, or like something as simple as not listening to parents or something was something that, you know, they didn't do, so I didn't do it.
Yeah, it's a good example. It's a scary example right now, especially with their teenagers. That's a scary one. It's a good point. Yes.
I just think sometimes when you get into a leadership position, it's easy to think that your skills got you there, or your ability, or even your personality, just things about you that might make you think you are somehow better or more capable than other people around you. But if you remember that you're only as good as them, not better and not worse, then it will probably humble you a little bit.
And why is that better for the organization? I agree with you.
Because it's better to lead with them rather than to pull them, dragging them, or try pushing them, and then walk with them. That's how a true leader leads.
Okay. Done a good job with your leadership concepts. Yes, exactly. And you'll see, and we've seen people, bosses that we work with, and they do think that. And they'll go around and, I've got my doctorate, so I know better than you guys. Or I've been a CEO of a Fortune 500 company, so I'm, you know, whatever. The problem with that is we know this, so I know this, but our CFO knows this. Our CNO knows this. Our CMO knows this. We all have very different personalities. And so if I were arrogant enough to think, oh, I know all the finance stuff, the hospital would have been closed in a couple of days. I mean, you know, I know it, but I do not know it like he does. That's his expertise. And the reason why, my personal opinion, this happens so much is because people tend to get afraid. And so they think, well, God, I don't know finances and I'm the CEO. I should know that, right? Because I'm in that job. I should know that. And so they get afraid and they want to pretend like they know this so that if I keep you kind of below me, it protects my role. I think that's rubbish. I think you look a lot better, and I think you look a lot smarter, but all the people around you make you look smart. Well, it's true. It's what he was talking about with your friends. If you're walking around with a bunch of kids that are smoking, what's the opinion going to be of that individual who isn't even smoking? Right? Yeah.
I kind of think about, like, I played basketball in high school, and it's like, it's all teamwork. Like, everything, when you're a leader, it's all teamwork. And, like, you can have a star basketball player on your team, and if they're not leading the team the way they need to, and they're not helping everybody else get better, you're not going to go anywhere, even though that star player is on your team. So you have to lift everybody up and just work as a team if you want to accomplish it.
Exactly. I'm going to challenge you that whatever you decide, like this is the principle for me, at times they'll get challenged. Even though we're talking about it now and it makes complete sense, there's times when you might really like the people you're with and they're smoking, or there's different, this is where the integrity comes from. or they're doing things in decision-making in the hospital. And by sitting silent, you're allowing them to do that. I mean, there's times where you really have to look in the mirror and remember these principles that you promised to yourself, whether it's personally or professionally, and go, okay, is this what I'm doing every day? And that, trust me, I worked for really, really great organizations. I've been very, very lucky. Worked in Bountiful, worked in Driggs, worked in here, as far as the large organizations, and they've all been great. But both of those have been challenged in those organizations. And it isn't that they're bad people, it's just business gets hard. Pressures and stresses get in the way, right? Other thoughts on you're only as good as those around you?
I was just gonna say, a leader does a lot of delegating. A leader can't do the job all themselves, so when you delegate the work to other people, they do the work too, so if they're doing a great job, you can't say you're doing a great job, or vice versa.
I love delegation. Yes, it's Ariel. Sorry. That's rude.
I'm Ariel, hi.
Sorry. I'm so sorry. This is Ariel. You know what? As far as making you look good, Ariel and Michelle are the assistants in the executive suite, and we wouldn't function without them at all. So you know, these ladies do wonderful things for us. So I'm so sorry. This is Ariel. But Ariel would probably attest to how awesome we are at delegating.
Some are better than others, it's a good thing to do.
But it's having those skills and knowing how to do it, and with the right motivation of trying to teach people in that process. If you delegate, you can hopefully teach people to do better at what they're doing, or help them grow to be, you know, the next leaders of tomorrow and different roles, and not being threatened that if you teach them what you know, that you're compromising your position in any way. Again, I think if you delegate and you teach and do all of that, you tend to look better. And quite frankly, your life's better too. You know, it makes it a lot easier. And so I look at people like, you're making this job much harder on yourself than it needs to be if you use teamwork, you use people's skill sets, you know. And then they're also tend to be a little more loyal to you. So when you're making mistakes and sidestepping, because you will, they might be willing to help correct that and help you, your teammate, back. And that's comforting, because you don't want to be in this alone. And again, everything I'm talking about starts applying at the front level as an RN. Absolutely. When you're leading other RNs, when you're leading physicians, because you will, when you're leading patients and families, right? It applies throughout the whole spectrum. And there isn't a difference in importance there, except the patients are the most important thing. You have to get that. Yes, sir.
Something you've been talking about, and it kind of makes me think about conflict, is that if you don't have same principles or same values, then there will be conflict within whatever business or organization you have.
Yep.
And so if you have people that are trying to go in a different direction and they don't want to change their mind, or they can't be convinced, other than, so like you talked about, some go a different segue than where they should be going, and the board of trustees is like, no, that's not where you're supposed to be going. Well, if they're stubborn, then they're just going to create more conflict and probably get fired eventually.
Yep.
So I mean, it just causes all this conflict. But if you have people that are similar or like-minded, or you're getting the cream of the crop, the people that are the most innovative or whatever it is, that'll help uplift and build and develop your business or organization.
Yeah. I would say that you don't want, and I don't think you meant it this way, I'm just clarifying. You don't want like-minded, but you want consistent values. And why I'm differentiating that is I was having fun this morning via text, and it's a lot of conversations with physicians that way. And the chief medical officer and I were kind of jiving each other back and forth. And he thinks very differently than I do. He was taught in medical school. I mean, he has a different personality, all sorts of things. But that very, very different perspective led to a better decision than if I were to have made it just on my own, because he was willing and should look at it from a very, very different perspective. I was kind of like, darn it, you're right. But kidding. It's like, okay, I see it, and so we went a different direction. But even though we weren't like-minded on that, we have the exact same value of where we wanted to get. I mean, not necessarily the goal, but the value of the organization. And so that part made it, okay, we can agree to disagree. This time I was like, yeah, okay, I'll give you 1 point on that one, But when you go to work for an organization, think about your primary values, and that's part of, well, it's a major reason why I love Madison. For me, family is so important, and it is a very family-oriented culture. And not that I'll use Irmac as an example. It's a great organization, but because of the nature of their business structure, it doesn't have the luxury as being as family-oriented as us. So for me, it's better to be able to work for a family-oriented culture, for example, than Eastern Ohio Regional Medical Center. I'm not saying that they're not family-friendly. I'm just saying that it's just different because it's a whole different business structure. So when you go to work for that organization, because you spend a lot of time at work, think about those values, whatever those are that are really important to you, and try it and test it out. Because when you go to apply for a job, it isn't just us interviewing you, you're interviewing us. Because if she's happier where she works, the patients will be happier. So remember, you have something to offer to people as well, right? And make sure it's what you want. And it isn't the same for all of us in here. It shouldn't be. It's going to be a real open one. Other thoughts on the, you're only as good as those around you? How are we doing? Okay. Yeah.
So I just had a situation, so I'm from Pennsylvania, and so I worked on a med surg floor for a while as a nursing aide. And there was a doctor, and he, instead of helping the nurses understand what he wanted and what he expected them to take care of, like how he expected them to take care of his patients, he just said, I just want these nurses and no one else touches my patients. And so that caused a lot of conflict, a lot of like patient overload on certain nurses, because now these nurses are getting all of these doctors' patients because no one else can take them. And so it just caused a lot of turmoil and just unhealthy work environment.
What would you have done if you were in charge of that? If you were the nurse leader in that area?
I don't know, honestly.
Anybody else got an idea what they would do?
Maybe if they're looking for something specific in the nurses, then maybe ask the doctors to either write down what they wanted or maybe work with some other nurses more so that they can train them what they like, so more nurses can take over for those other nurses.
Good idea. Who's right, the physician or the nurses?
Nurses.
It was a trick question.
No.
Yeah, what you find out most of the time is it's never that black and white when you get into these situations. And so it would take a lot to kind of dive into that and look at, okay, what's really going on here? Is it the skill set? Do we need to teach that to all nurses? But absolutely, that's the way to go. Or are these nurses going outside an area that is not necessarily one with the organization that they want, and we need to have a conversation with the physician? It just kind of depends. But it creates a lot of conflict if you don't address it right away. I might sidetrack right there for conflict. If I can teach you one thing today, it's don't be afraid of what's called conflict, but I would call it direct communication. It is the best friend you will have in healthcare. Okay, there's a lot of really cool things that would be really good for you, but let's go back to kind of the social setting. If I like her hair today, so I just think it's really cute because it's curly. But let's say I did. Let's say I'm kind of like, oh, why did she pull her hair out? She shouldn't. And I'm going to go to her and I'm going to talk about it. Instead of coming over to her and saying, you know, if you would leave your hair down, it would look a lot better. I'm making light of it. But making it silly, but that's because we do it all the time as human nature. And that is something, if you can start practicing with your friends and your loved ones, it'd be so great, and you'll be so much happier in healthcare, is learning how to go to that person and talk to them about whatever in a very kind and respectful way. You will also be loved by the organizations you get hired into if you can do that. But you'll be able to go home at the end of the day not carrying a lot of weight on you, right? So practice that with your friends and stuff. Yeah.
So thinking more about, because there are so many roles in healthcare, and
Yeah.
the major decisions are created by the trustees, and we learned about quality management and what really, because I haven't really interacted with CEOs of hospitals until lately, and it's more that my thought process is I don't know what the purpose serves. So what is your role in what you do to benefit the hospital? Because I don't know what you do.
Great question. You know, and that's changing. I think that's maybe what you're sensing a little. So CEOs used to be the big manager of the whole organization, if you will. But as healthcare got more complex, they got other executives in there to help with that. And so then you were managing your teams and kind of helping set strategic direction and working with your boards. Now it's changing a lot because we used to set have you gotten into strategic plans at all or read a little about them? No? It's kind of your guiding document of where you're going to go in X numbers of years. So you'd work with the board and you'd set a strategic plan for, and it used to be 3 to 5 years. And we'd say, okay, we're going to do these 5 things for the hospital in the next 3 to 5 years. And that's what the board, with input from the CEO would do their homework, they'd get all that information, and they would work with the board to set that strategy for the organization. And then kind of your job as far as a people manager in the organization for the rest of the time. So there's a long list of that. You've got a lot of responsibilities there. But the biggest role that's happening now with CEOs is that strategy. And the reason why is because Holly comes once a month, sometimes more, on a volunteer basis to help us set the strategy. Healthcare is changing so rapidly now that the strategic plans are now in very short cycles. So CEOs are even changing their titles to chief strategy officers. And they're asking the other executives in the team to kind of help the operations run. So your primary responsibility is to set or to make sure that the hospital is running well and you're working with your medical staff. That's your day-to-day job. But at the same time, and what I spend a lot of time doing now, is trying to help interpret where healthcare is going. And so that's where the strategy is coming in a lot now. And so I come back from different meetings and different things and different boards that I serve on and try to educate the board and say, okay, this is how healthcare is starting to change. We need to change our cycle as well.
And so with your time constraints, is it pretty independent what you do? Because I've seen Doug Crabtree at little events or talking with the nurses, and you're here right now talking to a class of what, like maybe less than 15 of us. And I looked you up on LinkedIn. I requested you, but you're still an adjunct faculty.
I'm kind of out of that. Sorry.
You're still an adjunct faculty at the University of Phoenix. And so would you say that the time constraints are pretty busy for a CEO, or do you have a very flexible schedule?
I have a flexible schedule in the time constraints, meaning that you have to be flexible. And poor Ariel and Michelle, they manage my schedule, and they do. And I walk up to Ariel, I'm like, okay, what time do I have X? And I literally asked her on the way up, when do we get lunch today? You know, I mean, Well, it's the questions, but I don't have to think about that stuff. They know what I need to do and they kind of help guide through that process and manage the schedule of it because it is, she can speak to that. It's hard. It's a full-time job for them to try to manage the schedules of getting people together. Trying to get the Crabtree night together is so fun. But right? They've done it and then we don't follow their rules sometimes and we make it more difficult and we kind of change it all up. I think that it depends on you have to be able to delegate, you have to be able to prioritize what's most important. There's always something to do, but are you spending your time the way that you really need to be spending your time? So you'll see Doug at a lot of different events because Doug and I are both social people. We like to talk to people. We like to learn from people. Then you know by going out and serving on boards and doing these other things, are you helping your organization go in the right direction? So he's keeping a pulse on what's going on. It's also why I teach, but I love to teach too. It's a very selfish moment because I love it. But then I keep my boots on the ground, if you will, instead of just sitting in my office and kind of forgetting what are the nurses doing on the floor? You know, what are they learning in education now? What, you know, there's so much to know that you've got to kind of balance that, and it's different for each CEO and how they balance all of those responsibilities. But then it goes back to, I can serve on the American Hospital Association board because I have a great team at the hospital. And so I can go and I can spend that time, I can learn those strategies, bring them back to the board and our hospital because I've got a great team. And so to answer your question, you gotta, yeah, you're married to the hospital because you love it. If you don't love it, and it's not a 24 or like an 8-hour, 9-hour day, I might, you know, leave early on a Friday or something, but then probably talking to somebody Friday night for a while, or a doctor, or even, you know, we have a doctor coming in this weekend. You know, it's just, it's a very flexible work schedule. I don't know, does that kind of summarize it?
She's busy, short answer, yes.
In lots of fun ways, though. It's
Yeah.
cool. Yeah.
Can I ask a question too? Earlier Holly was mentioning, we were talking about staffing and she mentioned staffing at Madison for the upcoming eclipse that's going to occur in August. And so I'm really interested as a CEO, how did you work through that? Who did you work through it? How did you make the decisions and what are you going to do?
So you should start with your front line to make the decisions as far as what do they need, the clinical directors in the areas, what do they need? What do we, I mean, we got the information as far as the projection of the people that are coming through our area. And so you get the information from our people in-house, as well as, because we're affiliated with ERMAC, we're working with them. And then we also, I asked the Idaho Hospital Association to work with the state. So it's kind of a coordination from the state level all the way down to the frontline level. And so we're making our decisions based on the best projections of the numbers that are coming out. And it's a fine balance because we're a county hospital. We don't have a huge surplus of dollars. And to spend a lot of money on staffing is a lot of money. And it's money you might be able to reinvest back into equipment or different things. But nurses like to be prepared. You love being prepared. Probably always have tape in your pocket. There's just these weird things that you do to be prepared. And it's the same thing. I think that just trusting that the clinical directors, the materials director, everyone knows exactly what they might need in a very pragmatic way. So we are preparing in some of the clinical areas. People will not be allowed to go on vacation. Ariel and I might literally be sleeping in the hospital in our offices. We've talked about that on cots. You know, we've got a wide range that we can flex and be flexible during that time. So you're there as runners and help however you can. Maybe we'll just be sitting there watching movies in my office. I don't know. You know, I mean, it's hard to really gauge that, so you gotta be prepared for the most and be able to flex down how you can. Did that answer where you were going with
That
that?
helps, so, yeah.
Our biggest concern, honestly, if you want to know the number one concern, is traffic. And we rely, traffic and communications are big. I mean, we can order in a certain amount of supplies to get prepared and kind of with staff, but we have staff that live in Idaho Falls. I live in Fremont County. And trying to get here in a timely fashion, that's why we're talking about, well, maybe some of us need to be in-house and stay closer. But the big concern is how do you get the ambulances down to Ermac? And so it may not be an influx of a huge amount of people, but just care for the people that we normally do. So that's why we have to stay involved. And so we just need more helicopters. Well, we only have a handful, and during that time, they get really busy with the park. And so they might need to be designated here. It'll be really interesting to see what happens with the eclipse from a system standpoint. And it's also really cool on how much it's teaching us to coordinate. When I was talking to the lieutenant governor, he's like, I just don't know if I want to, employ that much resources into this. And I said, wouldn't you rather look really great Idaho of how well prepared you were so there wasn't any type of news? Other than, look, if we have a major disaster, all the hospitals have this figured out. So you gotta learn politics too as a CEO. Any other questions on that?
That was great, thank you.
Do you think that will affect hiring? For example, if some of us are sitting here and we're like, oh, I want to work at Madison, and we apply when we graduate, do you think that specific event will kind of have an influence on how many people you hire or don't hire when you require them to start?
Probably not. I think that if there's the vacancies and things, I think that they won't. What it would affect is if they were doing new nurse orientation or if they were doing hiring new employees during that particular week. They might just flex it one way or another. We're always hiring nurses. And so I just don't. You guys are going into a really cool time as far as nurses. There's a great demand again. Great demand. I believe Ermac at the moment has 98 positions open. 25% vacancy rate. Go back in history. There's always a nursing or healthcare professional shortages going on. It's nothing different. It's just the time you're entering into. So it's kind of cool when you hit that. You entering like, where do I want to work? I'm sure that the nursing directors will. You don't want to hire someone, and if they felt the need, they would hire it as a temporary position because it would be a false promise if we didn't have the work after the eclipse. And so they would want to do that. Other questions on the eclipse or the film schedule of the CEO? In fact, it's fun. Okay. I'm going to cover two more quick things if I can. Okay. 12:10, right? Yeah. 12:15. Okay. Why would I even need to say when you're in a service organization, why would I even need the principle of maintaining my integrity at all costs? Hard question, huh? Yeah.
The thing that I think of immediately is a med error, because they just drill medication errors into us and the importance of taking care of them right away. And I wouldn't say I saw this in medicine, but sometimes in all healthcare places you can see nurses be kind of relaxed with certain situations. And if you accidentally pushed a drug or a medication that you knew wasn't really going to have probably any side effects on the patient, it would probably be pretty easy to chalk it up as, oh, I ended up wasting that medication because I pulled it, didn't need it then, and blah, 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 instead of actually taking care of the medication error. And the cost of that could be your job. It could be your license as a nurse admitting to a medication error. But keeping your integrity, no matter what, it could save somebody's life. It could potentially save your job instead of lying about it, and then eventually somebody does find out about it because the patient doesn't have an adverse reaction. So when I think of maintaining integrity, that's what I think of. Or a nurse, something that I see really frequently is a nurse saying, hey, can you sign this narcotic or co-sign this narcotic? But I already wasted it. And so when I was at clinical, my nurse, it was a nurse from another unit who asked her to do that. And she's like, we don't do that here. She's like, I need to see. She's like, you're going to have to talk to your charge nurse or something because I'm not going to co-sign something that you already pushed down the sink or whatever. So.
You'll find, have you ever looked on the CDC and seen about hand washing? Something you think is pretty basic.
Oh, yeah.
Nurses fudge on that all the time across the nation on proper hand washing. Why else would there be a national campaign on hand washing? To me, that's an integrity thing for the patients as well. Seems very basic.
Yeah.
How much time did our professors teach you to wash your hands properly, right?
Yeah.
So his point's very valid. And who are you cheating outside of the patients? Yourself, right? And so the hand washing, the faking of vital signs. Your blood pressure's been fine. It's been running about this. Oh, it happens, trust me.
Oh, yes.
It happens at Madison. We're not perfect. I don't know who, I don't know how, but unfortunately, it happens across the nursing profession, doesn't it? How in leadership would you need to maintain your integrity?
Holding others to higher standards is something really difficult that in the leadership positions I've had they're like, oh, you're being so sticky with such a minor thing, or you're just being mean or bossy or controlling, and even if you explain it in the best ways, you're gonna have some fight back because it's another requirement, another demand.
Yeah.
So holding true to your integrity, oh man, you don't wanna flake or give up just because it's hard.
It's a true test, isn't it? Yeah.
Sometimes you have to make decisions that are going to be better for the patient than for your bottom line. And I know that on an administration standpoint, money is a big factor. I mean, hospitals, they can't be running in the black all the time, or I mean in the red.
Yeah.
Wait, red.
Red.
Red's bad, right?
Red's
Black's
bad.
good. Yeah. I'm a nurse, let's do it. No. Anyways, so money can be a factor, and no matter whether it's a community hospital or it's a for-profit, the bottom line is going to be money, and sometimes things are going to cost more, but you might have to do that to keep the integrity of your hospital and your patients.
Absolutely. There's this theory that we're working on at Madison, and I'll tell you, it's a gamble. The movement from volume, so taking care of patients on an ongoing basis, to value, paying attention to the outcomes and getting paid for outcomes. We're the only organization in this little area that's making that leap. And we are doing it because it's the right thing for the patient. So if you come into our ER physicians are starting to learn, I don't know why I'm picking on you, but thank you for coming here for these stitches. Did you know that you could go to a primary care clinic and get it done for cheaper? So in essence, we're saying, thank you for coming, but don't come here again. That's integrity. Because what's the right thing for her? It would save her and the system and everyone if she didn't come to the ER for stitches. Even though the nurse gets paid because she came there, right? So it might be better for the nurse because she just got a paycheck out of her coming. But the integrity is the best thing for the patient and the healthcare system. Mind you, we do stitches awesome at the ER, and not everywhere is open 24/7. I'm just saying that there's an example where you really want to go to primary care before coming to the ER because it's going to cost you a couple more zeros than if you went to the health center here or if you went to primary care. And so there's so many different ways that your integrity could be challenged as a nurse or an executive, and you got to find that fine balance between keeping the doors open as a hospital and doing what's right for the patients. And so that's how we're, the board, and the rest of us are kind of doing this interesting dance back and forth. Yes?
So I'm actually doing my preceptorship at the Madison ER, And it is interesting because mostly when we do our discharge, we do talk about that, like, well, if you went to this facility or go to your primary care, that's where we want you to follow up, unless like something happens or you can't do it that specific day, then you could come back here, but it's gonna cost more. And it's things that they actually say, they talk about cost, that it does cost more. And I mean, that is on the patient's minds most of the time, and depending on their insurance.
It's a gamble from if you're looking at it just from a business perspective, right? Especially if you're telling your patients, I mean, if you went to Jamba Juice and they gave you a Jamba and they said, thank you for coming, please don't come again. I mean, when you kind of look at them funny. I mean, some patients hear that from us. And because it feels funny and it takes finesse on how you communicate it. And there's other ERs that you could go to and they're like, oh, please come back, please come back, please come back. I'm not saying anything against that, I'm just saying that we're going a different direction. And it's kind of cool to be able to work for an organization that puts that first. Yeah.
Sorry, I'm asking so many questions, but have you thought about the repercussions and how are you gonna make up for that loss of income? You know, because if the goal is reached and patients aren't coming to your hospital as much, you're gonna lose money. And if they're not listening to you, then you're gonna get a bunch of low cases that aren't really helping the hospital anyway, and they're time fillers really. So
We're strategically looking at business outside of the four walls of the hospital. To answer that question in a big way, yeah. Our numbers on an inpatient standpoint used to make more money on the inpatient, and outpatient was down here. They flopped. And again, would you rather be able to talk to a doctor on your iPhone, or do you want to get in the car and go to them? There's a lot of changes that you guys start thinking about. I'll throw one other thing for you to just know from a really big picture of integrity. So, poor Ariel has to listen to me complain when I come back from the American Hospital Association meetings because I'm frustrated and I whine and complain and I want to go back again. It's kind of strange, I know. But I get frustrated because of the core principles in healthcare. And I have the luxury of working for an organization that we've been talking about. So I'm not going to get in trouble from Holly or the other board members for speaking about what's right for patients, because I'm lucky that way. Other organizations, they have a responsibility, fiduciary, absolute responsibility to the shareholders, those who are earning money off of it. So it's a different responsibility. Nothing wrong with that. It's their responsibility. But I'll go into meetings, and here's an example. And you're sitting in a room full of people who are working for really large organizations who've been doing this a lot longer than I have, probably have a couple doctorates, whatever you want to say. And they'll say things like, I'll start to complain about this one a lot. And they're talking about economic classes and where healthcare should go. The lower class should just be accountable for their healthcare. Then we would solve healthcare is the innuendo, and these are the policy. It's a policy work I said. So Holly's laughing because she knows I don't keep my mouth quiet. And so I challenged all of them in the room. Have you ever been hungry? Have you ever had to work 2 jobs? Have you ever had to wonder if what you're buying for your kids and what you can afford for your kids? Do people go to McDonald's and not buy mangoes and all sorts of things just because they want to? Or is it because it's convenient and cheap? I mean, and then I had fun like accusing all of them of their gym memberships and things that people who are fighting for things can't necessarily take the time or their money to go and purchase and eat in certain ways. But we want to save the lower class, which that term just irritated me. The reason why I tie this back to integrity is every time I go, I'm surprised they invite me back because I say things like this. And I got invited to DC because, like, well, you'll just say it like it is. But again, I don't have the personal cost. I can be true to myself on where I work. And so, and again, I am not putting down the other organizations. It's just, it's a different structure and they don't have They have a different responsibility than I do. And so I'm in a cool position to be able to do that. But it's nice. And so again, if you kind of look at what you want, whatever role you're in, I can go home at the end of the day and know I can be true to myself. And then it's nice. So try to find that. It may not be Madison. It could be all sorts of things for you guys. So find out what that is for you and try to stick that way. And I guess one of the last things I'll say is we are not going to keep you as a nurse just because you have a nursing license. We like nurses who can think, who are willing to think outside of the box, who are willing to challenge processes, who are willing to look at other areas. We like personality. If she starts a better ID than you, but your personality is better than hers as far as patient care and caring for your patients, she's going to get the job. We can teach her to start the ID better. It's a lot harder to teach her to be kind to patients. That is a really, really cool thing that healthcare is finally learning. It's about a lot of other skill sets other than just your technical skills. Now they're very, very important, don't get me wrong. You need to be able to start an ID. But it's much easier to teach those than it is to be friendly, kind, and those attributes underneath stressful environments, right? It's taking healthcare a long time to learn that one. And I'm afraid that we will go back a little bit with professional shortages. As far as, oh, warm body, she's got an RN license, it's warm body. You don't want just a warm body canine for you or your loved ones, right? I so didn't follow my script, but as both of them know, I never do when I speak. And so I had other things, but other general questions or anything that I didn't answer, or did I bore you to death?
No.
Healthcare is cool. It's a great profession. Enjoy it. And another thing that Madison's really lucky for is we have a lot of new faces coming through all the time. I think it helps us keep fresh. Some of us have been in it for a while, no offense to Holly and I, but we get kind of stuck in the way that we did it. So it's nice that she gets the fresh approach from you guys all the time, and then we get it in Madison as well. So speak up, because that's how we learn. Anything else, Miss Holly?
No.
Okay.
Thank you so much for coming. Wonderful. Thank you.
We're all like lines up.
Like the basketball class. You know, when you build up fast.
It's a slow clap, man.
Thank you. You guys did a great job and asked wonderful questions. And, I feel certain that that was valuable, that you enjoyed it. I know I sure did too. So, great. Thanks.